Good morning, everyone. I hope you can see my screen.
Yes, we can.
And is it in full screen, if you don't mind?
Yes, it is.
Okay, so good morning, everyone. Thank you for removing time from your weekends to join this presentation. So I will try to make it as short and to the point as possible so that um, it don't waste too much of your weekend. So today we are going to be talking about acute myocardial infarction. I'm sure you've heard of this topic and some of us might have some problems with it. So we'll try to clear as much of it as possible today. So please confirm if the slide is moving.
It's moving, we can see.
Okay. So we'll start. So ischemic heart diseases is a group of heart diseases in which there is an inadequate supply of blood and oxygen to a portion of the myocardium. So the keywords here are inadequate supply of blood and oxygen to the portion of the myocardium. So this falls under acute coronary syndrome, which refers to a group of conditions that include ST elevation of myocardial infarction, that's STEMI, non-STEMI, and unstable angina. So myocardial infarction, that's the coagulative type of necrosis, meaning irreversible death of cardiac muscle, and is due to prolonged severe ischemia. Yeah. So why this topic? That's what you're talking about in this slide. So epidemiology of myocardial infarction. So AMI was traditionally considered less common in sub-Saharan Africa, including Kenya, compared to Western countries. However, the incidence is increasing, particularly in the urban areas like the big cities, Nairobi, Mombasa, Nakuru, Kisumu, due to lifestyle changes and the rise of cardiovascular risk factors. We'll see which are these risk factors in a bit. But a 2018 study published in the Pan-African Medical Journal indicated that cardiovascular diseases accounted for about 13% of all deaths in Kenya, with AMI contributing significantly to CVD-related mortality. AMI primarily affects older adults in Kenya, particularly those aged 40 and above. However, cases of younger individuals, particularly those with significant risk factors like hypertension or diabetes, are becoming more common. So males tend to have higher incidence of AMI than females, also, although this gap may narrow post-menopause due to hormonal changes in women. Urban areas such as Nairobi, Mombasa, Kisumu reported higher incidences of AMI compared to rural areas. This is attributed to the higher prevalence of cardiovascular risk factors. Okay, so what are these risk factors that we've been talking about? So we can group them into non-modifiable risk factors and modifiable risk factors. So non-modifiable risk factors are which ones? Like genetic abnormalities, family history, previous history of coronary artery disease, increasing age, male gender, and ethnicity. So these are the ones that we cannot do much about because they're non-modifiable. You either have them or you don't. While we have modifiable risk factors, which are now mostly due to lifestyle, hyperlipidemia, hypertension, diabetes, cigarette smoking, alcohol consumption, physical inactivity, homocystinemia, metabolic syndrome, and hypercoagulability. So these are the risk factors mostly coming about due to lifestyle. So pathogenesis, how does this occur, this myocardial infarction? So in coronary arteries with pre-existing or fixed atherosclerotic occlusion, inadequate coronary perfusion may occur due to new superimposed thrombosis and or coronary vasospasm. So in majority of the patients, MIs are caused by acute thrombosis within coronary arteries. Thrombus formation is due to acute plaque changes. So what's the sequence of events in a typical case of MI? So there's usually a plaque in most of the people in the blood vessels already. mostly due to hyperlipidemia, diabetes, and such causes. So increased activity, like when you'll notice most people have MIs when they are on exertion, when they have stress, when they are doing some physical activity. So the heart starts pumping faster, rushing blood into the vessels. So that blood which is rushing against the plaque might cause it to rupture. So what happens when it ruptures? Yeah, so there is this material, fatty material inside which gets exposed, and a thrombus forms on the ruptured plaque. So what happens after a thrombus forms? So it keeps getting bigger as it blocks the vessel. So now think of a pipe. Once it's blocked at one place, the downstream area doesn't get enough blood and oxygen in this case. So blood flow to the heart muscle starts to slow down. Yeah, so that's what you're talking about. So here is what you're talking about, acute plaque changes. Now that's the sudden disruption of the atheromatous plaque. These acute plaque changes convert partially occlusive atherosclerotic plaque to produce sudden ischemia. So these changes occur either through rupture or fissuring, erosion or ulceration, and hemorrhage. You can have hemorrhage in the central core of the plaque, which increases in size, and the end part of all this is the sudden occlusion of the lumen, the blood vessels of the heart. So once you have formation of microthrombi, acute plaque changes exposes thrombogenic subendothelial collagen. Platelets adhere to the site, platelet activation and aggregation occurs. Then there is formation of microthrombi on the atheromatous plaque, which causes partial or complete occlusion of the affected coronary artery. So when that happens, the blood vessel undergoes vasospasm. So the activated platelets, endothelial cell, and inflammatory cells release mediators which cause vasospasm at the sites of the atheroma, further narrowing the lumen. Then there is activation of the coagulation pathway, which is the one responsible for formation of the thrombus, complete occlusion of the vessel. This occurs within minutes. The thrombus may completely occlude the lumen of the vessel. So when that happens, the the body is not used to the heart having pain. But what happens is when the heart muscle is deprived of oxygen, yeah, so they send pain signals to the brain. So the brain actually kind of gets confused because it's not used to having pain from the heart. So because we have some nerves coming from the heart and coming from the arm and the shoulder, which meet at some point in the spinal cord and in the brain. So that is why you typically see most people having pain in their left shoulder, left arm, radiating to the jaw, the neck. So that's called referred pain, because the brain gets confused when it gets signals from the heart. It thinks it's coming from your arms, but actually it's coming from your heart. So the cardiomyocytes are running low on oxygen. The nice normal coordinated way in which your heart beats is compromised because some part of it is not receiving enough oxygen. And oxygen is required for it to produce energy, ATP, for it to contract. So the brain triggers a big surge of adrenaline release into the bloodstream. Yeah. And that's why you see the heart beats faster. But you see, the adrenaline is not going to do anything about the clot. The clot still is blocking off the blood supply to a part of the muscle. And that is what the mechanism is. So you can see here the blood supply of the heart and how this is the plaque which was already there. It's fixed, but now due to the increased work of the heart, the blood kind of erodes this plaque and it might even cause it to bleed, hemorrhage, and there is a thrombus formation. Yeah. So which clots the artery. So what is the clinical presentation of this? As we said, the classic presentation, you'll have an acute retrosternal chest pain, which is typically dull, squeezing pressure and tightness. That's what most patients will tell you in the ward, that they feel a very heavy thing on their chest and they feel it's very tight. It's like compressing their chest. It commonly radiates to the left chest, arm, shoulder, neck, jaw, and or epigastrium. That's due to the referred pain that we just talked about. And it is precipitated by exertion or stress because your heart is not able to beat properly already. And then when you have exertion, and that's where the blood is really gushing through the vessels, and that's where it uh, causes the plaque changes. So symptom relief after administration of nitrates, it's not a diagnostic criterion for cardiac ischemia. So why did I put this? As you know of this stable, so you must have heard about nitrates administration, and that's when it happens. But for myocardial infarction, administration of nitrates is not a diagnostic criterion. So the peak time usually is in the morning. The other symptoms you'll see are dyspnea, pallor, nausea, vomiting, diaphoresis, anxiety, dizziness, lightheadedness, and syncope. Yeah. So complications of myocardial infarction include tachycardia, which might cause arrhythmias. And arrhythmias is the most common complication of myocardial infarction, the most common and the most important one. And you can also have symptoms of heart failure, which can be orthopnea, pulmonary edema, or you can have a cardiogenic shock like hypotension, tachycardia, cold extremities. You can even hear a new heart murmur on some occasions on auscultation, like the new S4, which can be heard in some patients. So atypical presentations are more likely to be seen in elderly people, diabetic individuals, and women. So you can get a stabbing, sharp chest pain. Like we said earlier, the pain is usually a dull squeezing pressure, but in some, you can see a stabbing, a sharp chest pain with no or minimal chest pain. So that is called a silent MI. Sometimes you can have a myocardial infarction without any chest pain. That is more common in patients with diabetes. As we know that diabetes can cause polyneuropathy, in which the nerves are not very, we can say, sensitive, and so they could be having a MI, but they don't feel any pain. So you can also have autonomic symptoms like nausea and diaphoresis. So how do we classify these MIs? So there are different ways in which you can classify this. The first one being depending on the thickness of the myocardium involved. So we can have a transmural infarct. So what's that? Ischemic necrosis of the entire thickness of the ventricular wall. Transmural. Trans meaning spanning across and mural meaning the muscular wall. So it's a necrosis of the entire thickness of the ventricular wall. However, a narrow rim, approximately 0.1 millimeters, of the subendocardial myocardium is preserved due to diffusion of oxygen and nutrients from the ventricular lumen. So that 0.1 mm is the subendocardial myocardium, which is actually just in contact with the blood inside the heart. Yeah. So there can be diffusion of oxygen and nutrients from there, but otherwise the entire thickness of the heart is undergoing ischemic necrosis. Or you can have subendocardial or a non-transmural infarct. So now this is the opposite of transmural, where now the ischemic necrosis starts from the inside, and it's like the inner 1/3 to up to a half of the ventricular wall, which is affected. So why does that happen? Are there different types? So in a transmural infarct, which are actually the most common ones, it's usually associated with chronic coronary atherosclerosis, acute plaque changes, and superimposed thrombosis. Yeah. And the subendocardial infarct, which involves the inner 1/3, occurs due to plaque disruption followed by a coronary thrombus, which undergoes lysis, or it undergoes severe, or you can have that due to a severe reduction in the systemic BP. So when you have like a hypovolemia and your systemic BP really reduces, that is when you can see a subendocardial or non-transmural infarct. So that's depending on the thickness of the myocardium involved. You can also classify it depending on the ECG changes. So you can have a ST elevated myocardial infarct, or you can have a non-ST elevated myocardial infarct. We will see about ECGs in a minute, but how will you differentiate if this is a STEMI or a non-STEMI? If you have a ECG and there are no if there is no, of course, if there is ST elevation, you will say that this is ST elevated. But if there is no ST elevation, how will you know if this is a MI or not? We will come back to that in a few minutes. So depending on the age of the infarct, it can be a recent or a old, fresh or healed in that case, or depending on the anatomic region involved, you can have an anterior, posterior, lateral, septal, or a combination of the MI. So let's talk about the blood supply of the heart. We know that there are three major blood vessels of the heart, which are actually talked more about during myocardial infarctions. So there's the left anterior descending artery, which there's occlusion in 40 to 50% of the cases. So the LAD supplies blood to the anterior wall of the left ventricle near the apex, anterior portion of the ventricular septum, and apex circumferentially. Then we have the left circumflex coronary artery, which the occlusion occurs in 15 to 20% of the cases. And this primarily affects the lateral wall of the left ventricle, except at the apex. It doesn't affect the apex. The apex we said is affected by the LAD occlusion. So the right coronary artery occlusion, which is the third one, occurs in 30 to 40%. And it can be either the right coronary artery proximally or its posterior descending branch. So these vessels supply blood to the region of the inferior or the posterior wall of the left ventricle, posterior portion of the interventricular septum, and inferior and posterior right ventricular free wall in sum. So how do we diagnose someone who has who is having a myocardial infarction? As we know that this is kind of an emergency and we need to be fast with this, so we need to know these things uh, very well. So first you'll look at the clinical features. As we've talked about, the clinical features are the typical ones: the retrosternal chest pain radiating to the left arm, jaw, neck. Yeah. So we can do an ECG and we can check cardiac biomarkers. So we will do that now. So we'll start with ECG. So we might have seen ECGs being done in the wards. So a 12-lead ECG is the initial test in every patient with suspected myocardial ischemia. Findings include a pathological Q waves, ST segment shifts, and T wave inversions. So I would like to take some time here, as many people have requested me to talk about ECGs. So how do we place these leads? Starting from there, when we are trying to take an ECG, how do we place these leads? As we know that we have 6 leads, which are from V1 to V6. And then we have additionally 4 other leads, which we place on the arms and legs. So how do we place this? We can see in this picture that there's the right arm where we place the white one, the left arm black, then green and red on the legs. So on the right arm, this we might take some time here, so please bear with me. So there's the right arm, which has negative charges. On the left arm, we'll have positive and negative here, and then on the left leg is where we'll have the positives. So negatives go to positives. Yeah, you should remember that. And this triangle here. So this is lead 1. Can you see my cursor?
Yes, we can.
Yeah, so this is lead 1, where the charges are going from negative to positive this way. So how will we read that? We will read that as if we are looking from here. So if you keep your eye here, at the left. So you are seeing the negatives coming to you. So that is how the charge is moving. And then for this one, lead 2, we are looking at it. So the negative is here and the right arm, and the positive is at the left leg. So it's like we are looking at it from here. Keeping our eye here at the left leg, we are seeing the negative charges coming towards us. For the same, for lead 3, from the left arm to the left leg, you keep your eye here and see the charges moving this way. So that's how you interpret those, and that is how you will know which part you're looking at when you're looking at a lead 1, a lead 2, or lead 3. So that's for those leads. And for V1 to V6, how do we place those? So V1, we place it in the fourth intercostal space, which is in the right sternal edge. The right side of the sternum, you place it in the fourth intercostal space. So V2, you place it in the fourth intercostal space on the left sternal edge. So those two will kind of be together in the fourth intercostal space, right for V1 and left for V2. Then we skip V3 for now and we go to V4. So V4 will be in the fifth intercostal space in the mid-clavicular line. So you place it here in the fifth intercostal space in the mid-clavicular line, V4. So why did we skip V3? Because we place it in the middle of V2 and V4. You place it midway between V2 and V4. So that will be easier to place now. Then V5, where do we place V5? In the anterior axillary line in a straight line with V4. So you follow the line as V4 and you place it in the anterior axillary line. Then V6, you place it mid-axillary line in a straight line with V4 and V5. So it's still following the fifth intercostal space, but now you're placing it in the mid-axillary line for V6. I hope that is clear, how to place the leads. So now how do we interpret an ECG? As we've seen many ECGs, and we always wonder, what are all these lines and all these sections? How do we know which one is for what? So this table is the best to know that. So we start for for the lead 1. It will tell you if there is any pathology in the lateral wall. So why lateral? We can go back to this and we see V1, we had placed our eye here, and the negative charges are coming from the right arm to the left arm. So basically you are seeing the heart from the lateral wall over here. You can see the heart, you're seeing this lateral side of the heart. So that is why it tells you about the lateral. You can see leads 2 and 3. So 2 and 3, we said the negative is flowing from right arm to left leg, and 3 from the left arm to the left leg. So you had placed your eye down here to the positives. Yeah. So because you're placing your eye at the positive, the part of the heart that you can see here is the inferior part of the heart. For lead 1, we said the lateral here. And for lead 2 and lead 3, you're seeing the heart from the inferior wall. So together with AVL, which is lateral, and AVF, which is inferior. So going to the V1s to V6. So V1, where is V1 placed? V1 is, and V2, actually. V1 and V2, we are saying septal. These ones in blue. Why? Because you've placed the leads actually at the sternum, on the right and on the left of the sternum, and you can see that's where the interventricular septum will be. So that's how you remember that, V1 and V2 on the septum. So that will be around here. So you've placed V1 on this part and V2 here. So you are looking at this septum over here. V3 and V4, we can see that it's written anterior, the ones in pink. Why? Because look where V3 and V4 are placed. So if you had placed V1 and V2 here on the heart, so now V3 and V4 are here, literally on the anterior wall of the heart, of the left ventricle, the anterior wall of the left ventricle. Then see where V5 and V6 are placed. There we're looking at, and this is where V3 and V4 are. You're looking at the left, you're looking at the lateral side of the heart, the lateral wall. So again, V1, V2, septum, V3, V4, anterior, and then V5, V6 on the lateral. Okay, so this is the interpretation of the ECG, and we will do, so okay, let's talk about this. So infarction of the anterior wall is anterior wall is caused by the obstruction of the LAD. This is anatomy. We've learned this and we know this. So the anterior wall obstruction, it's because of the obstruction of the LAD. As we can see, this is the anterior wall and this is the LAD, which is supplying the anterior wall of the heart. Depending on the extent of the anterior wall infarction, it results in ECG changes from these leads, and we are going to talk about how. Infarction of the inferior wall is caused by obstruction of the left circumflex or the right coronary artery or the branches. And the ECG changes are seen in the leads 2, 3, and AVF. Okay, let's do some ECGs, and I would like some participation here, at least in the chat. You can write and you can tell me what you think. So this is the ECG, and we can see lead 1, 2, 3, and this is AVR, AVL, AVF, and then V1 to V6. So I can give you a hint here. We're talking about ST elevation here, because this is a STEMI. So this is the part that so this is a sinus rhythm, P, QRS complex, and T wave. This is the T wave, and this is the ST segment from S to T. You can concentrate on that and you can tell me what you think is the pathology in this one. Anyone? You can't see ST elevations? Okay, let's do it together then. So we can see lead 1. There is not really any elevation here. Lead 2, there is clear ST elevation. We can see here there is clear ST elevation in lead 2. Lead 3, also there is ST elevation. AVR, not really. There is no ST elevation. AVL, not really. AVF, we can see here again, we have these ST segment elevations. Yeah. And V1 to V6 doesn't seem to have any significant ST elevation. So which ones have we said? We've said lead 2, lead 3, and AVF having ST elevation. So let's come back to this. So lead 2, lead 3, and AVF. What do you think now? So yes, someone in the chat has said it's an inferior wall STEMI. So yes, that is correct because we talked about lead 2, lead 3, and AVF. So here. So this is the inferior STEMI, and the blood vessel which would be most likely affected or clotted here would be the right coronary artery, the inferior wall of the heart. So example 2. So here is lead 1, 2, 3, AVL, AVL, and AVF. So V1 to V6. So in which ones can you see ST elevations in this one? We can do it together. So lead 1, there's not really any significant elevation. Lead 2, the same. Lead 3 also, there's no ST elevation here. AVR, there's no ST elevation. AVL, there is no significant ST elevation here. AVF as well. But look at V1. You can see there is this ST segment elevation here. V2, there is a very clear ST elevation. Here we can see in these ones. In V3 as well, we can see very clear ST elevations. And we can see ST elevations in V4 as well. V5, there is, it's a bit, but it's not so much, but it's there. V6, not really, I can say. So V1, V2, V3, and V4. I hope you can remember where we placed them. We said V1 starting from the septum, the right, left, then V3 and V4. So we can come back to this and see V1, V2, V3, and V4. So which one do you think this is? Yes, this is an anteroseptal wall MI because you can see the anterior, the septal V1 and V2 and the anterior V3 and V4. We have ST segment elevations there. So which blood vessel is most likely affected for an anterior anteroseptal? So it's usually the most likely the left anterior descending artery where the occlusion is. So this really helps us to identify which vessel is most likely affected, and that helps us in the management and the interventions that we can do. So third example. So here we can see the leads again. So let's just dive into it. So lead 1, then there is no ST elevation. Lead 2, there is no elevation. Lead 3, no. These ones also, there are no ST elevations here. But look at V1, look at V2. Look at, okay, V1, the ST elevation is not really there. In fact, there is some sort of depression here, but it's there slightly. Look at V2. There is some elevation. V3, there is significant elevation here. V4 as well. V5, you can see this elevation. And V6, there is also some slight elevation. So what do you think this ECG is telling us? Where is the lesion? Which part of the heart? We said V2, 3, 4, 5, 6. So yeah, so we can say there is some sort of septal here. There is anterior V3 and V4, and there is lateral in V5 and V6. So that tells us this is an anterolateral MI, and there is also, so you can also septal actually because of V2. So when you have an anterolateral, now this is on the lateral side, the lateral wall of the heart. Which blood vessel are you thinking of? The left circumflex artery. As we can see here, the anterior and lateral, and you can see in the blood supply, this left circumflex, which is going towards the lateral wall. So that is most likely where the lesion is. Okay, so we've talked about ECGs, and that is how we determine how the stem is, which part of the heart they are affecting and which blood vessel is most likely the cause of it. So now I had asked a question. So how do you know that this person has a myocardial infarction if there is no ST elevation, the non-stem is? How do you know? So now you do cardiac biomarkers for that. Cardiac biomarkers are the ones which will tell you if there is a myocardial infarction or not. Those are the ones that will confirm. And which ones are these? The ones that we know of and the ones that are used mostly are the troponins, T and I, CKMB, and myoglobin. So troponins, they rise in the regular assay between 6 to 8 hours, and the highly sensitive troponin T and I tests, the rise will be in 1 to 3 hours. So the peak occurs in 12 to 24 hours, normalization in 7 to 10 days. So these biomarkers, the troponin T's and I's, they are a cardiac specific marker with high sensitivity and specificity for myocardial necrosis. So these are the preferred markers, And the highly sensitive troponin T and I, they are mostly used in the emergency and the A&Es because of the um, short time it takes to rise, and they are very cardio-specific. Then we have CKMB. So we know creatine kinase, it's there in many organs. It's there in the heart, in the skeletal muscles, in the brain. So the ones in the muscles will be CKMM, the skeletal muscles. In the brain, it will be CKBB. But the one of the heart, why do we not just take a total CK? It's because we have all these in the heart. We have in the heart, in the brain, and in the muscles as well. So CKMB, which is the specific one for heart, the rise will be in 4 to 9 hours, peak in 12 to 24 hours, and normalization in 2 to 3 days. So CKMB is more specific to cardiac tissue than total CK. Because if you just take a total CK, it could be elevated because of muscle trauma. It could be due to physical exertion. Post-op, if someone has had convulsions, the CKBB would be high, but the total CK will show you a picture that it's elevated. Yeah, so we take a CKMB, which can be helpful for evaluating reinfarction because of its short half-life. Then we have myoglobin. Now this one rises in 1 to 2 hours, peaks in 2 to 12 hours, and normalization occurs in 24 hours. So this one, the myoglobin will rise when there's damage to skeletal muscle or cardiac muscle. Yes. So that is why we have to be careful with this one. False positives can occur in a skeletal muscle injury and in renal failure. Yeah. So we have to be careful of those false positives. But if you are sure with the troponin T's and troponin I together with CKMB, myoglobin can also be a cardiac biomarker. So what are the additional lab tests which you would do if a patient comes to you? Obviously, you will do a complete blood count with markers of inflammation. You can do the hemoglobin. You have to evaluate for anemia if the patient needs blood, platelets for thrombocytopenia, and elevated inflammatory markers like increased WBCs and elevated CRP. Serum chemistries you will do UECs to evaluate for renal dysfunction and electrolyte imbalances. LDH and AST may be elevated due to cell necrosis. Yeah. Then we can do a BNP or NT-proBNP. So that may be elevated, especially in concurrent heart failure. When patients present with heart failure secondary to MI, you can have an elevated BNP. So you can also do a coagulation profile to evaluate for baseline coagulopathies and urine toxicology screening in suspected use of cocaine and methamphetamines. We know that these ones cause vasospasm, and that could be the cause of the angina or of the MI. So what else can we do? We've done ECG. We started by doing a history and physical examination. We saw the chest pain and we saw all that. We did an ECG in case of a STEMI. We did the cardiac biomarkers, and if they didn't tell us that there is an MI, the last thing you can do, or you can do it together with intervention, is coronary angiography. So how do you do this? It's the best test for definitive diagnosis of acute coronary occlusion to identify the site and degree of vessel occlusion. As you can see in this picture, this part, you see how it's very dark upstream, but after this occlusion, you can see it becomes lighter and some of the branches of the vessel are occluded. So this is the definitive diagnosis. This one, if you see it, then you will have to believe it. And this can be used for concurrent intervention. So once you've placed the wire inside through the vessels, and now you are inside the heart, you are inside the coronary artery, you can decide to place a stent. Yeah, percutaneous intervention. That's what PCI means. So you've gone through the skin, now you're inside the coronary artery and it's occluded. You can place a stent and widen the vessel to allow the blood flow. So you've allowed reperfusion. So the indications for this, it occurs in acute STEMI and end STEMI with timing dependent on risk factors. So management, how do we manage this now? Now we have a patient with AMI and all. Now how do we manage it? So the goals of therapy and AMI are is basically the restoration of normal coronary flow at the maximum salvage of functional myocardium. You want to restore blood flow as fast as you can. So the first thing you do, you'll give antiplatelet therapy and anticoagulation. So you can give dual antiplatelet therapy, which includes aspirin with a loading dose of 162 to 325 milligrams. Plus, you can give a ADP receptor inhibitor, yeah, like mostly clopidogrel. And anticoagulation you can give by unfractionated heparin or low molecular weight heparin. Yeah, so this is the first thing you would do. Then you can give supplemental oxygen because most of the patients will present with SpO2 less than 90. So you want to bring that up. In cases of cyanosis, you will bring that, but that's the only time you will give. You don't give it to all patients. You check this if there's cyanosis, severe dyspnea, or if there is oxygen at the SpO2 is less than 90, you give the supplemental oxygen. Next, you will give sublingual or IV nitrate, the nitroglycerins. So the primary benefit is the vasodilator effect of this, and it's metabolized to nitric oxide, and we know that is a potent vasodilator. But when do we not give it? This is important. The contraindication of this is when you have an inferior wall infarct. When you've seen the ECG and you've seen that the inferior wall is the one affected, you do not give nitroglycerin. Please remember this, because there is a risk of hypotension. When there's an inferior wall infarct and you give nitroglycerin, you might send the patient into hypotension. So morphine for the pain, you can give it IV or sub-Q. Beta blockers recommended within 12 hours of MI symptoms and continued indefinitely, reduces the myocardial mortality by decreasing the arrhythmogenic death, because it decreases the rate and force of MI contraction, myocardial contraction, and decreases the overall oxygen demand of the heart. Remember the MI, it was triggered by the increased activity of the heart with the plaque, but now you are slowing down the heart using beta blockers. Statins you will give to regardless of the baseline cholesterols, you'll give them as a prevention, and thrombolytics can be indicated in MI and ST segment elevation greater than 0.1 MV in 2 contiguous leads. So who present in less than 12 hours, but not more than 24 hours after the symptom onset. So 12 to 24 hours is your window to give thrombolytics, which are these: alteplase and reteplase. So remember that 12 to 24 hours. So this is, like, we all love mnemonics. You can remember this. I hope you all know what this painting is. So Monabash, morphine, oxygen, nitrates. But nitrates, remember, we don't give in inferior wall infarcts. Aspirin, beta blockers, ACE inhibitors, statins, and heparin. So this is the initial management of MI. If you remember this, you will do well. So percutaneous coronary intervention. We talked about this earlier, but we'll talk about it in management again because it's used in diagnostic and management. So it's an alternative if it's performed by a skilled operator in an experienced center. The standard is a door to balloon time of 90 minutes. 90 minutes is the time in which, like, since the patient walked in, up to you place the stent, it should be within 90 minutes. And within the 90 minutes, if you do it, the success rate is restoring blood flow in 90 to 95% of MI patients. Yeah. You can see how the stent goes in and it pushes out this mesh, and the stent widens the artery, which restores the blood flow in the vessel. So long-term management, obviously, we're not going to leave the patient to go home that, okay, we have sorted your issue, you can now go home. Obviously, they're going to be taking medications in order to prevent future events of getting a myocardial infarction again. So lifestyle modifications, obviously, we'll have to do that. We'll have to tell the patient to lose weight, to do exercise. There is lipid lowering therapy, like atorvastatins, we'll give them. Antiplatelet therapy, we'll have to, that will be a lifelong dose of aspirin, 75 to 100 milligrams per day, or you can give them dual antiplatelet therapy. And you have to manage the comorbidities. If they have hypertension and diabetes, hyperlipidemia, all those will have to be controlled so that they don't get future episodes of myocardial infarction. Other cardioprotective drugs, you can give beta blockers and ACE inhibitors. So yeah, that one will require clinical judgment on how you'll do that. Beta blockers, it says that all patients should be started on a beta blocker to reduce the heart rate of the patient, and ACE inhibitors in STEMI, heart failure, and hypertension cases. Prevention, of course, is better than cure. So lifestyle modifications you can do is smoking cessation, healthy plant-based diet, regular physical activity, and exercise. Those are the lifestyle changes that you will ask the patients to do. Management of comorbidities. If you have hypertension, if you have diabetes, make sure you're going to your clinics. You advise your patients to be regular and have those things under control. And you can give a low dose aspirin, which is beneficial for certain high risk groups. Yeah. So thank you. Does anyone have any questions or comments?
Thank you, Umang. I think we can all agree that you have simplified such a complicated subject for everyone.
Thank you. Thank you. If there are any questions or comments, you can ask them now.
We will have a session for Q&A shortly, but for now, can we go on to the Kahoot?
Yes, sure.
So I'm going to display the Kahoot pin and sorry, I'm experiencing some network issues, but I'm saying that I'll display the Kahoot pin on my screen and everyone can join then. Devangi, Sajni, can you guys please join Kahoot? Deepa, please don't shy away from competition and please join the Kahoot. Okay, I'll start the quiz and whoever wants to join in a little later can do so. Thank you to everyone who participated and congratulations to our winners. If anyone has any questions regarding this presentation, you're free to unmute and ask. Yeah, I think among everyone really understood this, and I don't think there are any questions. With that, I would like to conclude this presentation and seminar. Thank you everyone for joining. Please don't forget to subscribe to XYZEZ's YouTube and follow us on Instagram and LinkedIn and Twitter. And there's an ongoing study. I will share the link in the chat box or in the community channel. Thank you so much, and thank you, Umang.